So we're welcoming everybody to our webinar. If you see the Buddha on the road, kill him. This is the first of a series of webinars that we're really looking forward to sharing. This one and the two following will be free. They'll be on Substack, edited, and we really encourage you to go ahead, watch, join the discussion, make commentary. If you're already doing strategic therapy, you might like to share some of what you're doing. If you're not and would like to introduce it or to be doing it more skillfully, please join in the discussions. We're really looking forward to having those chats with you. So we're very fortunate today to have Professor James Coyne with us. James has a remarkable history. He is a walking, talking encyclopedia of psychology, and one of the things that really thrills me about James is that all of the textbooks I've ever read and the seminal writers and developers in psychology, James has pretty much worked with all of them. So that's rather mind-boggling. But James rose from a welfare and public housing position to Emeritus Professor of Psychology and Psychiatry at Penn, where he was co-director of Cancer Prevention and Control and Senior Fellow at the Leonard Davis Institute and Centre for Clinical Epidemiology and Biostatistics. He held faculty positions at Berkeley and Michigan, visiting professorships at Rutgers, Groningen and Australian National University, and Carnegie Centenary Visiting Professorship at Stirling University. He's written over 400 papers and is designated amongst the 200 most eminent psychologists of the late 20th century, one of the most cited researchers that we have. So very, very pleased to have James here and really looking forward to his discussions. His work with strategic therapy and depression goes way, way back to his roots with the brief therapy team at MRI. And so what I'd like to open with is asking you, James, why your approach to depression is so different to most other people's.
For that, I got an offer to go to Michigan, and one thing led to another, and I found myself in the Department of Family Medicine and the Department of Psychiatry at University of Michigan. It's a pretty prestigious place. And they wanted me to do research, but they would allow me to see 8 patients a week. And that was more of a favor to me because I said I needed to keep in touch with clinical work than anything special. And I became quite well known for taking patients from people that no one wanted. And also they had a specialty mood disorders clinic where they attracted severely depressed people who hadn't been benefited from any treatment. They'd be on multiple medications. They'd be very, very depressed. And they would take them on an inpatient unit and take them off all their medications and then rebuild the medications. And when they got out, often their life was in ruins because they'd been chronically depressed. And so I was supposed to do something to get them going. No one there believed that I was treating depression. They believed that I was helping people readjust after having been depressed.
Oh, okay.
So depression is a disease.
Because they didn't believe these people had depression.
Well, they believed they had depression, but they didn't have anything that would be treated with psychotherapy. A lot of the staff believed they had a medical condition that ruined their life. They needed help by a therapist, if you wanted to call it that. And so I adapted what I was doing in Palo Alto, and none of these patients said they wanted to bring their spouse in. Sometimes the spouse wanted to come in, but I started saying, give my usual rap, that sometimes you don't have to be part of the problem to be part of the solution. No one's blaming you. There's a lot of blame to go around. There's a lot of disappointment, hurt, and frustration. But the point is that by coming in, you're making a commitment to be part of the solution. And so it's very non-blaming. And people sort of like that. But still, I have to say, back then especially, maybe still now, men have a bias against believing that they will benefit from psychotherapy. They worry somewhat that it makes them seem as weak. Some of them do, but some of them just feel that they're problem solvers. They don't need talk. They need action.
Yeah.
And so I had to appeal to that.
Yeah.
And so basically I found myself surrounded by people coming in to see me who didn't want to be there, who were very skeptical I'd be able to do anything for them.
Yeah. Yeah.
I adapted to that new environment. And all of a sudden I realized I was doing something nobody else was doing. And it became a bit of sensation among the residents. And they started saying, you can take my patient because I'm a failure, but I really would like to watch what you're doing.
Yeah.
So
Watch
we
and learn.
recreate the situation where there'd be a team watching. But the residents was too intimidated to try to tell me what to do. And, it was the hierarchy. And so they just came and legends became, built on what people saw, and often it was exaggerated. But eventually, I don't know how, but a women's magazine, Good Housekeeping, gave me an award for the depression therapist to see in Michigan. And so I started getting referrals from people who had read about me in women's magazines. And that just seemed all the more bizarre.
That's when you put your price up, James.
Pardon?
That's when you put your price up.
Yeah, exactly. Yeah, but see, I was working in a system where my pay didn't depend on it.
Yeah.
And so I do controversial things. Like I felt sometimes that 15 minutes into a therapy session, you accomplish what you wanted to do. And if you kept talking another 35 minutes, then you might ruin it because you'd undo it.
You've changed the focus.
And so I would say, well, okay, I'm only going to bill you for 15 minutes. And so the secretary would say, how can you do that? And I said, the psychiatrists do that all the time. Sometimes it only takes 15 minutes to check meds. I was just checking their relationships.
Yeah, and they're moving on. And James, you've got a terrific story about getting a very reluctant husband into therapy, haven't you, with his sweet wife?
Yeah,
would you share that story?
It kind of got a thing where I was particularly interested because I come from a below the working class background, but I felt I could relate better sometimes to the practically minding working class patients than the more intellectual patients from the academic community. And I remember one case in particular. The wife's complaint was that she was terrorized by her husband throwing things and screaming. And she was very clear that it never was aimed at her. It just seemed a bit of frustration. And so what you do in strategic therapy is you start asking for details. You want to be able to imagine a videotape of what was actually going on behaviorally. And she described that they would be disagreeing, and he would raise his voice, a big guy, and she would get more quiet, intimidated, and sometimes she just froze and stared at him. And that would be furious because she felt she had castrated him. That here he was, this big, powerful guy, and he was laid low by her not speaking at all. And he felt that she should be fixed. That was her problem. So he didn't want to come in. And so in the third session, I said to her, why don't you tell your husband that I'm so confused by what such a nice, calm, loving woman could drive a man crazy. There must be some part of the story that I'm missing. Could he come and set the record straight? And we could have a man-to-man talk. In fact, you can introduce him, but I think I should meet with him behind closed doors because he might be able to tell me something about you. And she laughed. She said, you know what about me? I said, of course. but your husband is skeptical, and he won't buy into this. He may not buy into it at all unless he can be heard out. So he came in and he described exactly the sequence. And one was a scary one where he got upset with her and there was something on TV he didn't like. And so he threw things at the TV and he broke the TV with an object. And I said, well, that'd be terrifying. He said, well, it's not like I broke her jaw. I broke the TV. And so then I said, when I think of you, wife, I think of her like a doe, like a deer. You think of her like a doe, she ruins my life. I said, well, maybe. I said, do you hunt? He said, yeah. I said, deer hunting season comes, yeah. And I know some of you guys out there where you live that you sometimes use lights, bright lights, to freeze the deer. Did you ever see a deer freeze? He said, well, I didn't do that on purpose, but one time I was out in the truck and I saw the deer in the headlights and he froze. And I couldn't avoid hitting them, and so then I took them and we ate them. And he said, I said, some people do that. It's illegal. But he said, I didn't do it illegal. It was an accident. Okay. But do you ever think that, imagine that deer staring into your truck as you plowed into him, and that maybe your deer was frozen like your wife freezes. He says that's the stupidest thing I've ever heard. I said, well, I don't know. We've run out of time. I think you should come back. He said, I'm not sure I want to come back. I hope I set you straight. I said, okay, but the next time that this happens, could you imagine the deer? In fact, if you could have something like that happen before the next session, it'd be good because I'd have something to talk to. If you have a good week, I don't have anything to talk to. And so I sent them out, and she came back next week and said, my husband thought you were a jerk, but you're very nice.
Yes.
And I said, what about the freezing thing? I don't know. We didn't get around to it. Well, why not? She said, I don't know. We'd have a disagreement, and we would just talk a bit about it, and he would listen. And he still didn't always agree, but I didn't feel so intimidated.
Yeah.
And so we went a few more sessions. She said, I came in because I was freezing up. I'm not doing that now. And you've been very helpful, but I don't see any reason to see you anymore.
Yeah.
I said, well, that's fine because you had 10 sessions and you used 7. And so you've got 3 in the bank if you ever need them.
Yeah.
So
terrific.
if you get up there and you feel things are out of control, then don't you say, I'll just call Dr. Coyne next week. And so I did a follow-up with her. She never came back. And she said, oh, hi, Dr. Coyne. There are times when I thought I should see you, but I figured I didn't want to waste the sessions. So we've just dealt with it. And he's not perfect, but he's a good provider. Yeah. And he really isn't violent toward me. No. And I guess it's not what you might want for your sister or your daughter, but it's a marriage that works for me.
Yeah. So James, can we unpack that? Because that in fact was a really brief intervention, wasn't it? You gave him the visceral experience of smacking into that deer and having the blood all over the windscreen, etc. And he was repelled by that. He thought you were a jerk, etc., etc. And you'd already asked him to think of his wife as the doe. You described her as the doe. So it would be very difficult for him now in those situations to not see the blood and see her as the doe. You stopped him in his tracks, didn't you?
Absolutely. So I come from a very uneducated background. And when I went to college, I felt I had to learn everything that people knew that I didn't know. And of all things, I started reading poetry. And I read Ezra Pound, who had a theory of objective correlative. That sounds like a fancy thing. but basically he felt his poetry should evoke an emotion with a graphic image. And so I felt it was very important with this man to give him something graphic that would keep his attention. And so it had to be bloody. It had to be detailed.
Oh, you found it.
And to get there, I didn't go in there with the idea that that's what I would do. I felt I needed to get a response out of him. So I just listened to him and asked for a lot of details that first puzzled him that I'd be interested in. And I certainly didn't jump on the fact that he had a pickup truck with a gun rack.
No.
But I figured that's one thing different that he might want to talk about. And I knew that people who did that were uncomfortable shooting deer that way. Because it was illegal. They could be arrested.
Yes.
And so
beautifully, and then you knitted the metaphors together perfectly, and he got the reaction there right in front of you, so you knew it hit.
But the problem that if say there was a resident watching them, a psychiatric resident, and some of them, frankly, they become psychiatrists because they don't like talking to patients. They like giving out the meds.
And they like being prescriptive.
Yes, and so they might go to the next patient that the woman is intimidated and has fears about domestic violence, and give them an assignment to imagine the deer, and the guy doesn't hunt, or he thinks it's silly. And so there's a whole art to reeling the person in by asking them questions. Now, there was something I believed at the time, and I don't know if it was true, but it was very helpful. When I had watched Václavic hypnotize patients, that he would often develop a cadence. In fact, sometimes he would tap. And what he would do is he would start talking about the weather and the surf in California or something. But the thing was to say things that people agreed with. And so they'd be nodding. And the whole body thing, they were participating in the conversation and agreeing. Only then would he throw in an intervention. And when they're still caught up in the being compliant.
And they're kind of entranced by that point.
Right.
Because it's
so
rhythmic.
And you don't jump in and say, I'm hypnotizing you, go do this. You and I remember a session I observed with him where he yawned and he asked me to go out and get him a cup of coffee. And he asked the woman who was being was supposedly in a trance, did you want a coffee too? And so they both had coffee. And at the end, I said, Paul, you broke the trance. He said, what trance? I said, he says, you believe in trances? He said, I don't know. I mean, I'm learning hypnosis from you. It's very confusing. And he said, well, I don't believe in trances. And I believe that I needed her attention. We're both tired, so we need coffee. And I said, well, that's common sense, but it's not common sense. And so a lot of the things I did were radically common sense, but sound strange. And one thing phrase I learned from the team, confusion is our most important product. And that doesn't mean what it meant back then. Back then, Ronnie Reagan, who was going to eventually be president of the United States, used to be selling stuff for GE or Westinghouse, and he'd always come on the commercials and say, you're buying a product, but progress is our most important. And so it was just banter based on that. So I started working in ideas, and it was very much kind of a whole body thing where you think about that about things in terms of bodily involvement and emotion. And it was nowhere near as complicated as the way some people would come in later. It was anti-analytic. It was anti-insight. It was just how do you persuade people to do something that they say they can't do but they want to,
Yeah, yeah.
or
And where are the resources? Where are the resources within that person? And you can't put an arbitrary framework on that. It's exploration, isn't it?
it's and the belief is there's a reality out there, and you can't change it, and but you can reframe it. Might have different outcomes.
Mm,
So
mm,
I was very uncomfortable that I didn't fully understand what I was doing. So I started reading about things. I started reading
mm,
about
mm.
social construction and things like that. There's a power to refraining, but you can't get people to believe anything you want them to believe because it has to
Yeah,
feel real for them.
yeah.
And so I was different
Yes,
than some of
yes,
the other
yes.
therapists at the time. I didn't believe in magic. I didn't believe in fantasy. I didn't believe that you could sell people a bill of bum goods, but you
Mm.
might be able to get them to experiment in their own life and discover
Mm.
things weren't as bad as they thought.
Yeah, yeah, yeah. And experiment in a way that made sense to them and met their
To them,
worldview.
only them. Yeah.
Yeah, yeah. Not, it wasn't some guru's world view being foisted upon them.
It
They
was, it
weren't
was, it
given
was
theoretical
yeah,
explanations. Yeah. So
like,
there's another interesting case you talked about, James, which is where you were explaining that sometimes what's needed is not therapy at all, but just a way to get unstuck. And there was the lady who was, I think, an amputee.
oh, that
Recall
was a very
discussing
horrible
that
case.
case?
Yeah, yeah, yeah.
Yeah. So would you explain that one as an illustration of what's often needed
Sure.
is not therapy?
Um, uh, she was a, she and her husband were bikers, and she had stopped using drugs because she was pregnant, and they were out riding on her bike, on his motorcycle, and she went into labor. And for some reason, I don't know if it had something to do with the bike ride or whatever, but she started hemorrhaging during the delivery. And in the panic, because this was not a planned delivery, it was, it was,
Mm, mm.
she went into labor
Traumatic
off
delivery.
schedule.
Yeah.
And so in the confusion, they introduced an infection. And in a very short time, she became septic and developed gangrene and lost her legs. And so this was a horrendous thing for them. And by the time they got to see me, she had been suicidal for a while. But then they told her she's going to go to MRI, and the people can deal with this sort of thing. And so she actually had gotten a bit better by the time she came in. So one of the things you always do in strategic therapy, one of the details you always collect is why are you coming in now rather than waiting
And
for a
yeah,
few months or
yeah,
before? And she
yeah.
said, before I was just so devastated. And she said, it was like when my father molested me. And I thought, oh my God. The analyst would say, now we're going to talk about molestation. We're going to talk about things that happened 20
Mm,
years ago, and we can't
mm,
solve the problem at hand. And I was sitting there and I could see in her jeans the metal from the prosthetic devices. So I was constantly reminded. And I said, well, what do you think the next task is? And she says, I really want to go back to work. And I may not look like it, but I'm a good accountant. And when I go back to work, it's okay that I don't have my legs. And I said, well, then how's it a problem? And she said, well, my husband is starting to smoke dope again, and I don't feel I can leave him with the baby. And so I said, that's the problem, that your husband smokes dope. And she said, yeah. And I said, well, you mentioned about your father molesting you. She said, yeah. I said, how did you get through that? She says, I don't know. I just did what I had to do. I coped. I said, well, whatever you have, I wish we could bottle it because there are a lot of people who can't get past those kind of things. She said, she laughed. She said, yeah, that'd be great. And so I saw him and I asked him, he described being a construction worker and cutting the concrete in the particular task he had. And he mentioned that he smoked dope to mellow out, and that, but she was pestering him to stop smoking, and that sometimes irritated him, and he needed smoking. That happened.
Yeah.
And so I said, well, for next session, why don't you start telling him about not smoking dope, and you say he's stoned and he can't function, and he sometimes says he's not stoned. You've got to guess whether he smokes afterwards, and you keep track of each time that you have that task. Did he actually get out of it so he couldn't work with the babies? And so it turns out that what happened was that he got the message he can't smoke dope right now. He had to be responsible. And it was kind of a silly thing to talk about. And I said, well, how did you solve it? He said, I don't know. I just coped. I wish I could tell you. And I said, well, maybe you could have a whole line of products. There's a men's coping and a woman's coping. Because it doesn't, what works for men doesn't work for women, you know? And you don't use your wife's perfume for deodorant and go to work, do you? And so that was last I saw them, because they had a real task ahead, but they knew what they needed to do. And they had a vague confidence that it would work out.
Yeah, and it did.
Now, the emphasis on vague, because if I said, do this and you'll get better, then they can have a failure experiences. But if you leave it vague and confusing, then maybe they'll never explain it. But they know how to get it back, is to play the game again. Yeah.
Yeah, they have to wonder about how this is going to work out, not how this is not going to work out.
Right. And sometimes I don't believe that people cope like they do when you read psychology books. They sit there stopping and thinking, what should I do next?
Yeah.
And they do, and the cognitions are all working in there. I think now sometimes people are more primitive than that. They just do something automatic. And so you want to get the automatic. And that, Christine, is where
that's the bit you need on side. So some people say there isn't such a thing really as depression. How should we think of depression? What is depression?
Well, it's different things to different people. If you ask people what bothers you most about your life, sometimes they'll say my depression. When I was at Michigan, that would be absolutely what they would say. If you ask one of these women, well, my depression has kept me laid low for so long, I can't remember what it was like to be normal. And my big issue is getting that out of my life. On the other hand, somebody whose problems were more tied to their marriage might say, my marriage is the problem. It's depressing to be in this marriage.
Yeah.
And so I would leave it up to the patient and the spouse to decide what they wanted to focus on, their depression or their marriage.
Mm.
But because I was on a biologically oriented unit, I was much more aware of the what they called the phenomenology of depression. And psychiatrists use that word different than psychologists. Psychologists use phenomenology like existential, like like Frankl, Viktor Frankl or something like that.
Yeah.
Phenomenology for a traditionally trained psychiatrist, old style, is the nature of the report that people give.
And the symptomatology.
And so what I learned, practically speaking, so people would say, I'm just really exhausted. And so I'd ask them, how do you feel exhaustion? And what was interesting is that a lot of people, when they're exhausted, say, "Oh, I'm just worn out. I can't think straight. I'm in a fog." But certain severely depressed people would say, "It's in my limbs. It's my arms and legs.
Yeah.
I can't lift them. They're
Yeah.
so heavy."
The heaviness. Yeah.
Or they'd say, "I can't sleep, but I'm so exhausted that I have to squirm all the time to stay awake during the day." And so I realized that there were different descriptions of being exhausted. And I would realize that some of them didn't sound like they'd respond just to get up and exercise.
Yeah.
Because some of my patients, in fact, when they start to recover, they resume exercise because they could follow a routine. When they started to relapse, the warning sign was they couldn't force themselves to exercise.
Yeah. Yeah.
And so I got much more aware that depressions in a context and relationships matter, but depression's also a real bummer that may be so strange to someone who's not depressed they can't understand. And so that validated, reinforced my idea that some people are dealing with something different. And I don't know what's going on. I'll depend on them. But come back to my simple assumption. Regardless of what is happening, renegotiating the relationships might be really important for the recovery.
Their relationships,
Right.
Yeah. And you talked about how important it was, not to be overly positive with these particular clients, not to dispute their negativity, by trying to get them to think or speak more logically, not taking their side, because when they feel better, if you've taken their side against others around them, when they feel better, they're going to hold that against you.
Oh, I learned it from hard knocks because I came into therapy thinking I was going to engineer stuff, and I would cheer them up because they seemed demoralized. And I felt I was like a football coach. Do it for the gimper, like the Ronald Reagan movie. The football team, the coach is dying, but go out there and win for him, And the people wouldn't, was not persuasive. And often they felt they had to defend themselves that things were bad. So I found if I reversed the dance, then I would really say, your life is really horrible. How could I possibly help you? What little thing would give you a ray of hope? Because we can overcome, and I made up this term that I got from, or Paul Watts made it. I don't want to be overwhelmed with therapeutic enthusiasm for being to help you, because that would be following my view, not yours. So I'll defer to you. What little thing, bare thing, would convince you it's not totally hopeless?
Yeah.
So you get people think small, not big. And
I think of that. You're kind of like the Columbo of psychotherapy.
He was my hero. Yeah. I always liked the idea that he'd interview people and he wouldn't be making too much sense. And then he'd get out and he'd walk towards the door. There was always the Columbo moment. And they'd turn around and say, one more question. And that's when he would catch people off guard. In fact, I found ethical problems with this, but I found that if I walked people out the clinic door rather than just letting them leave my office, we often had conversations along the way that they wouldn't say in the room. And I could sometimes do a parting shot with them and say, I don't know. I remember an extreme case. We had a broken coffee percolator, a little glass thing in the coffee. We had old-fashioned coffee machines. And it was sitting there, and I grabbed the little glass thing, and I gave it to the patient, and I said, this is for you. And they said, well, thank you. What should I do with it? I don't know. Come back and tell me what you did with it. Maybe it's like a rabbit's foot.
Yeah, maybe.
Yeah, but so the idea is that you're being very directive but you're not telling the person what to do, so they
Yeah.
can't argue with you.
Yeah. Yeah. You're
So if you
asking a
tell
question that
people,
they have to answer.
so if a person wants to do dreams, I say, I really don't do dreams. I'm not good at that. And they said, well, I'd like to do dreams. Okay. And so I'll say, why don't you have a dream this week? Maybe it'll be a nightmare and you feel you can let go, or maybe a happy dream, or maybe it's just a dream in color. I don't know the difference. But at some point you'll have a dream this week and you know you've been changed. Well,
It's
how will I
very
know?
Ericksonian.
It can be, but what was missing about Eric, to me, what I found offensive about Erickson is he really believed that he was a guru.
Oh, he did. His ego was gigantic.
Yeah, and my thing is, hey, I'm just a therapist. I'm dyslexic. I can't remember names. That was a problem. My disability is my strength of my ADHD or neural difference is that if I'm only seeing 8 patients a week, I can think about each one of them. And I have good episodic memory. If I ask for details, I'll remember the details. But I just can't remember names. And so it gets to be awkward where I'd try to get people in a situation where they said their names or recalled. But the nightmare situation I got into was dealing with a couple where the man had left his wife because he was going to have a trial separation. And he got involved with his secretary. And that was a horrible experience. So he came back. But he was gone for a while. It was a trial separation. I always say a trial separation is a trial divorce.
Yeah.
But if people do that, fine. So he came back, and he was obsessed with the fact that his wife had a date, and he was jealous. He didn't believe her when it said nothing really happened. And so when he'd get comfortable having returned home, they'd try to get on with their lives. He would start obsessing about what actually happened between them. And did she enjoy him more, the guy, than him? Well, I'm caught up in this conversation, trying to get into the details, and I make the mistake of calling him the other guy's name. And he got really angry. I said, wait a minute. I said, why did I make that mistake? He says, I don't know. Maybe you've got a problem. I said, maybe you have a problem. Your wife was so confused that she thought she was with the old you, not the guy that was cheating. And she didn't really cheat on you. If you believe her, I don't know if you can believe her. Well, I do believe her, but then I start worrying. I said, well, I get a way to put a stop to that, but it's so crude and ugly, you probably don't want to do it. He says, I'll do it. Well, the problem is, I know people say, you'll do what I say, and the one thing they won't do is what they need to do. So I have to build some trust with you before I tell you what my idea is. He says, look, this is ruining our lives. I'll do whatever. I said, no. Okay, what you'll do is rather than waiting for you to get comfortable and then tense, you should get tense and then get comfortable. Because when this all works out, don't you feel better? She said, yeah, I feel better, but we can't go through the same way. I said, okay, I'm going to give her a script, and you should follow it carefully. She should write it down. And whenever you feel you want to ask her, what was he like? And you should do it at least a couple times at the beginning of the week. So you've done it for the week and you don't have to keep doing it. So you should say, what was he like? And she would say, Doug, and Doug is your name, not his name. We got that right. She'll say, Doug, I don't know what he did, but he was so little, but it was amazing. And he said, that's disgusting. She didn't do anything with him. I said, that's not the point. We both agreed that she probably didn't do anything with this guy, but that's not the problem. The problem is that you keep being curious. This cat will kill your curiosity.
Yeah, yeah. So, James, this strategic therapy, and you could talk to that example specifically. It is quite manipulative of the client. It's getting the client to do what the client needs to do in order to resolve whatever's going on. So what do you say to claims that this is a manipulative approach to doing psychotherapy?
Well, I hope so, because people come to therapy because they want change, and often they just get talk. And I think they get cheated. Yeah. And, it's interesting because people used to compare me to Carl Rogers, and I thought that's the furthest thing in the world. That I'm more like Albert Ellis, I think. And they had these movies back then that compare the glory of the same patient. But in some ways, I am empathic and interested in a way that other therapists aren't. Mm-hmm. I just want the details of their everyday life, and I don't want to let my theory get too much in the way. Yeah.
You're intensely curious.
And so, in fact, sometimes when I felt really guilty, I struggled doing this therapy at first. I stopped thinking I was a bad therapist because I now was doing something I was comfortable. But it did feel manipulative, and some of my colleagues criticized that. So I would say to patients, we could talk for 10 sessions, or we could talk as long as we needed to do for a lot less, and then I could get you to do something. I feel guilty if you would feel manipulated. Would you feel manipulated if you felt better? No, I'm here to feel better. I don't want to talk. So what I was drawing on is that sometimes telling the people the truth is very disarming.
Yes.
If you say, I'm going to manipulate you, is it okay? They say, oh, no, I don't want to be manipulated. I just want to spend 20 sessions with you. No, they don't say that. They'll say, I'm here to change. So I do informed consent. And but then I realized people didn't do that. When I'd be doing videotapes, that was always very complicated back then, about whether it was ethical to videotape people.
Oh, yeah.
So a standard thing, they were more concerned about the ethics of showing a videotape and someone saying something that would reveal who they were. So they have a standard consent with it say, there's no guarantee. What they would say is there's no guarantee that if you have a pink poodle with 3 legs, if it mentions in the therapy, people will realize there's only one person in California that has a pink poodle with 3 legs, and you'll be exposed. No guarantee. So that was our concern, confidentiality, not the manipulation.
Yeah. So what about the client who, maybe has read a lot of psychology and comes along deeply desiring insight into some issue that they have? What's your view on insight in psychotherapy?
Well, I think insight's rather arbitrary. So that if I'm a Jungian therapist, God forbid, but if I were a Jungian therapist, people would talk my language, and they would have these experiences that were, of the collective unconscious or all of that spacey stuff. Yeah. But if I was Freudian, they'd dream of penises, and or at least the therapist would convince them that they were really dreaming of penises and butts, the anal or oral, and so I think insights is rather arbitrary. I'd rather have people create their own insights.
Yeah.
I'd rather send them out confused and they come back with a original thought about what's happened, which I won't argue with.
Yeah, because it comes from their own psyche. It's not the
Yeah,
psyche of a guru who made up a
right.
whole world of explanations. It's their
Yeah,
own
I mean,
psyche.
I'm not like a Fritz Perls. I'm not, he was real in back then. You know, they'd get naked at Esalen and he'd be a guru and all that. And you know, I don't
Yeah.
like getting naked with patients.
No,
And
no,
but they did
I'm not
is
known to.
always talk about inner stuff being inside. And I talk about people being inside, stuff being inside, but they don't know until they talk about it.
Yeah.
So when I
Yeah.
write a paper, I don't know the paper in my head. I write bad, mediocre stuff on my computer, and I correct it, and I said, that's what I wanted to say. So
Yeah.
you develop insight from engaging the world and discovering
Yeah.
what was
Yeah.
really going on,
It's
not by
afterwards, isn't
keeping in
it?
your
In
head.
review.
Yeah. There
Yeah.
was an expression that's really stuck with me at the time. In Siberia, they had had a thaw, and so Eskimos or whatever the natives are up in Siberia was they could feed their dogs the thawed mammoth because the mammoth had been frozen. Maybe that's what mammoths do and ancient elephants, whatever. But your past is not frozen in your head, and so I would say that it's if your past is still involving you, it's because you're interacting in the everyday life. So sometimes the way to deal with the past is to confront it in the present.
Yeah.
And if
Yeah.
you're not finding it, then good riddance.
Yeah. Yeah.
In fact,
Yeah.
there's some severely traumatized people, like the woman who had been sexually abused and had lost her legs, that it's better to pave over all that. You don't want to feel you suppressing it. You're just making it irrelevant.
Exactly. Yeah, you don't need to go back and you don't need to dwell and try to resolve all of that because in fact, it might not really exist in the here and
Right.
now. So why would you go back and re-traumatize a person? It makes no sense.
Absolutely. Yeah.
So,
Now, I know I'm talking to you and I'm talking to the audience, most of whom aren't strategic, and most of them are not inclined to do what I'm saying to do.
and we'll
I
have
say
some
that's,
arguments against it, which we look forward to
and so
hearing.
I would say, fine, if you don't need to do it, just do what you're doing if you're content.
Yeah.
But every now and then you may get stuck and you feel desperate to try something different or better. Sometimes therapy is going so well, it's so uneventful that you feel you can experiment a little with this develop insight with homework tasks rather than just sitting around talking in the room.
Yeah.
So wait till you're desperate or wait till you're comfortable. But otherwise, don't listen to me.
So, James, this is really interesting. I'm thinking of our discussions online that follow this with listeners, people who are interested in learning more about strategic therapy and how they might implement it in their clinics. How would you feel about doing case studies or doing a live session with a therapist who's interested in applying this with a particular client?
Well, one thing, I don't know about the legality of doing this across borders, but I gave up my license because I didn't want to take courses and continuing ed courses. It cost money, and I wasn't seeing patients. I was just doing research and writing. So I can't provide supervision towards licensure. But if someone wants a consultation, I can train.
Yeah, you can train.
And so what people could do is they could give me a report about their patient, and we could follow a template.
Yeah, and some patients may be very willing to be videoed in the interest of progress.
I mean, a lot of people, I found that a lot of people thrive on that. And the idea, but what I used to do, some people don't. So I used to do a weird thing that worked out real well. I was giving a workshop in Toronto, and there are 250 people in the audience, and I'd never done an audience that big. And I had patients who wanted to be seen. So what I did is I pulled the curtains, and we had the videotape running behind the curtains so they couldn't see the audience, but the audience could see them.
Yeah,
and then what I would do is say, I've got 250 therapists here. I can't imagine you ever getting a chance for 250 therapists to ever give her advice on a case again. So this is very special. I'm going to see you 20 minutes, and then you're going to go and you can go and have some soft drinks in the back or some coffee. I'll go out on a stage and get a consultation, and then I'll convene. The curtains will still be closed, and we'll talk about just you and me, the couple and me. We'll talk about what this 250 people have to say. Yeah, and maybe I can give them some feedback, or if you feel really comfortable, that might not happen, but you might want to just walk out and thank them and give them some feedback. And if they tell you something wrong, you're free to go out there and tell them they did something wrong. Yeah, they paid good money to come and tell me to tell them they did something wrong, so you can do it for me.
Yeah.
And it got to be a thing that it got very attractive to some patients that say, Coyne's coming to town. Can we go be seen behind the curtain?
Yeah, fabulous. And such value for the audience. Absolutely great value. So I guess we need to wrap up now, but I wonder, can I ask, in psychotherapy, we've got like a million different schools of theory. And the proliferation of modalities doesn't seem like stopping anytime soon. They just keep coming and coming.
Right.
We've got especially CBT and its multitude of derivations, DBT, etc. There's ACT, acceptance and commitment. There's mindfulness. There's family systems. Like it just goes on and on and on. All of these, without exception, are birthed by gurus. So what does a sane, aware therapist who seriously wants to provide the best science-based therapy that they can, how do they approach this?
Well, they first need some humility. They're not a guru, and if they are, then they're at risk of putting their patient in trouble because they're going to stop listening to the patient. My thing is, if you don't know what to do, you don't draw on your theory, you ask your patient. And if you still don't know, you didn't ask your patient enough. Think of Columbo. He has his theories about what's going on, but he has to get the patient to say them. And so it's being willing to be an anti-guru, where you just go and put yourself at the mercy of what occurs in the conversation. And be honest, an awful lot of strategic therapy is pretty boring to watch once you know what's going on. Because there aren't dramatic people aren't getting upset, and they're not talking to empty chairs. They're not role playing. They're just talking to you.
They're not learning about their parts.
And a lot of people just love the attention. The problem with psychoanalysis is they never talk to you. They don't even look at you. In traditional analysis, you can't see them. They're behind they're sitting in the back of the couch. And this is the opposite. I talk a lot.
So it's this intense curiosity about what's actually happening in the client's head, in the client's world, without judgment, without preconceived theories about why, along with a humility that what you've learned may not apply here.
But you can't be too curious. If you're curious what goes on in people's minds, you get a Netflix subscription.
Oh, yeah.
Yeah, because you don't want to depend too much on clients meeting your needs. That being a professional means if someone said, I saw this, an old girlfriend, and just after I broke up with my current one, not curious about what that girlfriend looked like or whatever,
No,
unless it's relevant.
no. Yeah,
And so
yeah,
you got to be
yeah,
careful of being a voyeur in people's lives, of,
yeah,
of,
yeah,
of being, curiosity is a mixed bag.
yeah,
The traditional things, curiosity killed the cat. There are things that the monks felt it was a vice to be too curious about things that were forbidden.
mm,
And
mm,
so I feel I only, if I'm at my best, I'm only interested in the facts that fit or
yeah,
that make the
yeah,
person comfortable talking about them because
yeah,
they need to.
yeah. So again, like Columbo, you're hot on the trail of something in your curiosity. So your curiosity, what's the best way of putting this? It's targeted curiosity.
It's targeted. And
Yeah.
it's deliberately taken the attitude of not knowing.
Yes,
I
yes.
may know from my theory, I may know from 15 patients that I've seen just like this one, this is probably what's going to happen. But I suspend that confidence and I act like I don't know, and I need them to
Mm.
tell me.
I've enjoyed this very much, James, and I hope that those watching might like to put aside the guru therapies that they maybe have become very emotionally attached to take this more open, directed, curious approach to their clients and discover from the client what the client needs in order to get the outcomes that the client says they want.
I couldn't put it better.
So if we see the guru on the road, if we see the Buddha on the road, we will happily kill him.
You can, because he's not the Buddha.
No. So we'll put this video up. Once it's edited, we'll put this video up on Substack, invite people to comment and engage with us on the points raised and maybe on some of the stories that were reported here. And I think watch this space for some live interaction with therapists, potentially with clients, um, using this strategic approach. So
Sure.
I look forward to collaborating on that as
But
well.
we should offer people, they're doing us a favor by bringing a client in, and we'll
Yes.
do them the favor of allowing them to tell us what happened, and we'll give them feedback. So
Sounds
we won't
great.
throw them out the door, never to see them again,
Mm, mm.
but we'll make it a learning experience because
Yeah.
they go out and do their assignment and they come back just like clients do with me.
Yeah, yeah. I can't wait. I think it's going to be a lot of fun, very exciting. Look forward to all the great conversations. James, thank you for today. It's been marvelous and we'll talk soon.